Sir, welcome. Samir sir, welcome.
Thank you. Welcome.
Actually, second wave has become more furious. So, breathing time भी से दौनी. All our doctors are running around.
Busy. Busy.
So, there's good number of participation. Around 100, 150 हो चुके. बाकी YouTube रे many people are watching the discussion. हमारा YouTube link का मैं रखी दूँ चु. YouTube रे चालू छी. In another 2-3 minutes we'll start, sir.
ये ब्रज के दास के को डिपार्टमेंट?
सर हमारा additional DMT.
अच्छा, ठीक.
He'll just start the procedure. ये हमारा FMT professor, sir.
FMT, अच्छा.
कौन आज को आउट की सर सबमिशन पे सब कौन कर आईसीयू मैनेजमेंट तो
सर नमस्कार.
नमस्कार.
Professor CBK Mahanti joining, sir. Professor CBK Mahanti, sir, welcome.
John, तो मैंने I am busy for some other works. मैंने Raja will take part, but the only thing मैंने I will suggest that.
Sir.
Dr. Sahu is very strong in ICU. Strong in knowledge about the ICU care. At least everybody will be benefited, and let us compile the names who are trained so that we can practically engage them in the different ICU facilities. Because every year we are giving training to so many persons, but nobody is willing to go for the ICU care at least. To participate in ICU care, at least during these deliberations, you please motivate them and find out the name of participant so that we'll take steps for their deployment and therefore for appropriate utilization of their services. Thank you.
Sir, thank you, sir.
Thank you.
So, good afternoon, everyone. Welcome to Health and Family Welfare COVID-19 State Grand Round. And as our DMT sir has already mentioned, we need to learn more and more about critical care medicine. And every time we require the knowledge in ICU to manage sick patients, starting from the non-invasive and invasive ventilation, as well as the management of shock and related complications. So it's the time your knowledge in critical care medicine need to be enhanced. So with our series of grand rounds today, we present you Dr. Shamir Shahu, the father of critical care in Odisha, who has been into field almost 40 years back, who is a MD medicine, MD pulmonary medicine, and been attached to Apollo Hospital, Kalinga Hospital, now the head of critical care services at Amri Hospital, Bhubaneswar. He has been the instrumental in spreading the knowledge and the efficiency of critical care medicine in the state, and for the purpose he has started the Bhubaneswar chapter of Indian Society of Critical Care Medicine, and this has become so vital and so necessary during this COVID crisis that we must congratulate him for his effort and for spreading the knowledge in the state. And to start the proceeding, we have already invited our DMT sir and also our additional DMT sir, Professor BK Das, is connected to us. And I request Professor Das to just start the program so that we can listen to Dr. Shamir Shahu on management of COVID-19 patients in second wave, a case-based discussion, and we'll be taking your questions following.
Good afternoon, all.
Yeah, Professor Das.
Thank you, Professor Jayant Panda, sir, for coordinating such activities on behalf of Health Department twice in a week. In every week, it has been a fixed slot where all the doctors of the state are being trained by eminent persons who are active in this field of COVID management. So, actually, Professor Samir Sahu, sir, needs no introduction, as our DMD sir has already told, that he is a man who is synonymous with ICU care in Odisha, who has practically started this discipline of critical care medicine in Odisha, and has made it popular. Now that such a stream exists and the need of this critical care has been emphasized because of this pandemic. Lot of people are interested to, a lot of persons are being treated in the critical care units in oxygen support, and a lot of training has been done. But we are practically seeing what we are calling inadequacy. Actually, our resources are being stretched, and we are not in a position, we are not having the adequately trained manpower to give ICU care. So, in this type of things, we need pearls of wisdom from persons who are active in this field for last more than 40 years, and that he has, and we are very happy that he shares it uh, uh, freely. Last week there was some doubts in our mind about the oxygen use. I asked Professor Niveda Madam to give us some things, and she was also not having that too much literature. So she asked Samir sir, and we got what we call ready reckoners about oxygen use, and basing on those things, we could formulate how, what the state policy, how that oxygen should be used, when to step up the use of oxygen. So all these things have been lucidly explained to us by sir. So definitely all those people who are participating today will be having a very clear idea regarding the management of cases in ICU because of the liberation of Dr. Sahu. So with these words, I will thank Professor Panda and all other persons who have joined this session organized by Health and Family Welfare Department. Thank you.
Thank you, Professor Das. It has been a continued activity by Department of Health and Family Welfare, and we have updated you in various aspects like mask, like oxygen therapy, like prone positioning, like mild, moderate, and severe case management. And this time we have Dr. Shahu with us, who will take us through the critical care management as well as the case-based discussion so far as the second wave patients are concerned. Without much delay, I invite Dr. Shahu for his presentation and ask all of you to keep your questions ready and post them in the chat box so that you'll be answered those questions at the end of the discussion. And second thing, we'll be having series of such presentations every Tuesday and Thursday on various topics, and you can also visit the link, YouTube link of these programs, and also update yourself if you are not free now and missing the program though you want to attend. So I welcome Dr. Shamir Shahu and request him to start his presentation and share the screen. Samir sir.
Thank you, Dr. Panda, and all delegates, DMT and additional DMT. Now, today I will give you 5 cases which we have encountered during the second wave, discussing all aspects of management and what we have learned over the last 1 year and what we need to do in the future. So this is the second wave we have seen. We had the first wave. This is our AMRE cases. In September, we had the peak. Now in April, we have crossed that peak of September. And we expect that May will be probably more than April. So this is the first case I want to present. Is an 80-year-old male, diabetic. He developed fever, vomiting after he took a second vaccination on 8th April. And this problem continued for 15 days. And he visited a OPD 3 times in between. Once he started having breathless on exertion or slight breathlessness, he met me in the OPD on 28th. But before that, he had met the physician in the OPD. He had got a RT-PCR done on 24th, which was positive. Then on 28th, he went and got a CT scan done. And then he came to me on 28th. That time, his saturation was around 95% in room air. I said, you are feeling breathless. If your saturation goes down to less than 90%, please get admitted. So in 2 days' time, his saturation dipped. He stays near our hospital, and he happens to be the grandfather of one of my colleagues. So on 30th, he came to the hospital. His respiration rate had gone up to 34. His saturation had dropped to 85. His temperature was still there. So last 15 days, he was having temperature. His temperature was 101.8. He did a CRP, it was 15. D-dimer was 901. He was admitted, started on remdesivir, Dexona, enoxaparin, piperacillin, tazobactam, vitamin C, and zinc. And ultimately, he needed oxygen for around 7-8 days. And ultimately, he was discharged home. But during discharge, he had developed a little bit of renal dysfunction. His baseline renal function was 0.9 creatinine, 1.9, but he went back home with drugs yesterday. So the point I want to make is, this is a patient who, when he came to me in the OPD, was having moderate problems. So his saturation had not dropped to 94 less, but he had a high risk of disease. So this is a patient who needed to be monitored. The second part of it is, he was continuously having fever for the last 15 days. And that started after his second vaccination. So we were always in a doubt, was the vaccination responsible for the fever or something else is responsible for the fever? Now we have started seeing a lot of patients who have gone to the vaccination center and come back and got infected. And basically the elderly people, because they were at home shielded over the last 1 year. And when they went out to the vaccination center, they came across a lot of crowd, have got infected and come back. The only thing is, for him to become serious, it took us 15 days. So we actually didn't think that he was having COVID in the initial 2 or 3 visits. But ultimately, he became severe. So his saturation dropped to 90%, his respiration went up to 30%, and he ultimately got admitted. But he improved with steroids, oxygen, and went back home. So what you need to know as a clinician is, if someone, see, normally this disease becomes all right in 7 days' time. The type of patients which we are getting now are having fever for more than 7 days. So if the fever comes or increases after 7 days, or he has fever for 3-4 days and he has remission and then again recurrence of fever, that means this patient is going into the inflammatory stage. Or he has very high fever, or he starts having severe cough, or new onset of symptoms, we are seeing loose motions, vomiting coming in. So these are the patients who have finished their viral stage, are going into the inflammatory stage, and those are the people who need to be monitored closely and start looking for a hospital bed. Now, in the treatment of COVID-19, we have basic 4 types of treatment. The first one is to develop your passive immunity by monoclonal antibodies. This option is not available here. We are trying with convalescent plasma, but which has not been effective. Then we have antiviral drugs. The only drug which we are still using is remdesivir. Faviplu and other things are not very effective. The third thing where we can save lives is when the patient goes into the hyperinflation stage, we can start steroids. And lastly, this is a disease where we have lot of thrombosis. So to prevent complications of thrombosis, we use heparin. So these are the 4 types of treatment which is available for COVID-19. Now the important thing is when to use which drug at which stage. That is important. If you start using steroids when the virus is replicating, you may land up in trouble. If you delay the use of immune suppression, when the immune overreaction has started, then the patient may die. So that clinical acumen which you have to develop over the last 1 year, this is what we have learned. Now, what you need to know is all these drugs which we are using have not been found to be effective. So it is time now we rethink and send proper message that these are the drugs which should not be used anymore. After 1 year of research, we have found that these drugs do not work. And today I was reading a message that all the hydrochloroquine which went from India, it was lying in one warehouse, which they have now discarded in America. Now, the drug which is in the news is remdesivir. And people are going from pillar to post. A racket has been found with spurious remdesivir, and people are unnecessarily running around after remdesivir. So all these studies which have shown that remdesivir doesn't make any difference to the patient's improvement. All the parameters of remdesivir have not been found to be any beneficial. So this is not an effective drug, and that is why WHO has, in its therapeutic of COVID-19, latest on 31st March also, it has said that remdesivir should not be used. National Institute of Health, USA, was the first to recommend remdesivir for people who had minimal oxygen use, but they have again degraded the evidence from A to B, moderate. So now it is time that we tell the public, we tell our doctors that remdesivir it's not a magic bullet. We shouldn't be running after it. If you have it, you can use it. If you don't have it, don't bother. The only thing over the last 1 year which has actually made a difference is corticosteroids. And this is a meta-analysis of all the studies of corticosteroids which have shown benefit. And this corticosteroid, according to the WHO therapeutics recommendation of 31st March, systemic corticosteroid should be used in severe or critical COVID-19 infections. You should start it after 7 days, but if the patient is deteriorating before 7 days, you can also start it much earlier. But for non-severe COVID patients, you should not be using corticosteroids. The dose equivalence is 6 milligram of dexamethasone, which is equivalent to 40 milligram of prednisolone, which is equivalent to 32 milligram of methylprednisolone. But apart from this, there are many questions unanswered as far as corticosteroids is concerned. What should be the type of corticosteroids? If dexamethasone is better, or methylprednisolone is better, or prednisolone is better, or hydrocortisone is better, we don't know. What is the duration of corticosteroids? All the severe patients, they have recommended 5 to 10 days. But we see people prescribing for months together. Then when to start it and when to hike up the dose. So these are still questions unanswered as far as corticosteroid is concerned. The next part for treatment of COVID is oxygen, 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 and oxygen. And again, in the second wave, this has come to highlight because the number of cases have increased. We have not got enough oxygen infrastructure in most of our public hospitals. So that is why it has become a big news now. So all you have to do is the first case which I presented, he needed a little bit of oxygen, a nasal cannula, a oxygen concentrator which the government has bought, or many of the district headquarter hospitals or COVID centers have got oxygen concentrator. These type patients we can manage, but we actually brought his oxygen requirement down because we started steroids on admission. So that was the changing thing. So he was getting into the inflammatory stage. So steroids were started, oxygen was given, and in 10 days' time, he did not need any oxygen and was able to go back home. So this is the type of patients which you can manage at smaller levels, at district headquarter levels where you don't have much ICU, HDU, a little bit of oxygen monitoring. So you got to have enough oxygen to use for these patients. And you should know that the oxygen concentrator only gives you 95% oxygen. And the most of the oxygen concentrators are 5 liter capacity, 5 liter per minute capacity. So they cannot give you so much of oxygen. So people who are needing minimal oxygen or people who are going back home with minimal oxygen, oxygen concentrator will do. The classical way of you giving oxygen in our hospital is the B-type cylinder or 1500 liter cylinder. The type of amount of oxygen which a serious COVID patient needs, this type of cylinder will not be enough. You will have to have 5,000 jumbo cylinders. And it is best to have jumbo cylinders in a manifold and have a pipeline. So today I was reading the Bolangir Medical College pipeline is going to be inaugurated in a few days' time. So all public hospitals have to have an infrastructure of jumbo cylinders, a pipeline, and at least some oxygen supply to the acute areas. So this is what our health administrators have to plan for the future. Now coming to the next case. This is a 39-year-old male who had fever and shortness of breath in the last 8 days. He came in because 8 days had passed and he was having little breathlessness. We said it's better to admit him in the ward. So he was admitted in the ward. On admission, his saturation was only 99% in room air. So Fabiflu was started, but because he was still having fever and shortness of breath by day 8, we decided to start steroids and enoxaparin for all hospitalized patients. On day 4 of admission, his saturation started dropping. He started needing oxygen. And from 5 liters, by night, it turned to 12 liters, and then he had to be shifted to the ICU. So you imagine he was there in the hospital for 3 days or 4 days, and suddenly in one day, he started deteriorating. So it's on the 11th or 12th day, suddenly there was hyperinflation stage, and he started deteriorating. So that is when we shifted him to the ICU. He was started on remdesivir. Steroid dose was hiked, and then enoxaparin dose also was hiked. The lab parameter CRP was not very high, 1.5. So this is what we did. We did a CT. CT scoring, the radiologist says 25 by 25. So while in the hospital, within 3 to 4 days, this is what he landed up with. So this is typically a hyperinflammatory stage. Now, to start nintedanib or not, this was the clinician's choice, but he was managed with oxygen and very high flow of oxygen for a few days. And once we hiked the steroids, he started improving. And then by day 21, we were able to shift him to the ward. Not the ward, the non-COVID ICU. And there he needed non-invasive ventilation for 5 days. Gradually, once he started improving, he started reducing the steroids. And today he is on 2 liters of oxygen nasal cannula in 91%. Maybe in another week's time, he can go home. So this is what I'm telling you is such patients you cannot know when he is going to deteriorate. So because he was in the hospital and we were monitoring him in the ward, we had to intervene early. And these are the patients which we can salvage by immediately hiking steroids and cutting down the inflammation. So these are type of patients which you may be seeing, hearing from the news. Suddenly someone deteriorates, someone dies, someone comes with a saturation of 60 or 50 and all that. So you have to look out for these patients. This patient, when he got admitted, we never thought that he will have this. So some people will have hyperinflation, and you have to be very careful and watchful for these patients. Now, these are patients where you need oxygen. This is one of the ways of giving very high oxygen levels. It's called a high flow nasal cannula. I don't know if the government sector have bought it or not, public sector. Many of the private hospitals have got this. We already have one, but we don't use it so frequently. Now, what are the things you need to manage acute respiratory failure in these type of patients? Patient is on nasal cannula. We can have awake self-proning. People are advising awake self-proning at home. I don't like it because I don't know if the patient or the patient relative can find out when the patient is deteriorating, because only watching the oxygen saturation is not your goal. When the patient needs to be hospitalized, what is his respiratory rate, what is his other discomfort, you got to know. So unnecessarily postponing admission to the hospital by trying awake self-proning at home in the initial stages of your respiratory failure, I do not advocate. Now, high flow nasal oxygen is one of the ways of giving high oxygen to the patient, because these are all hypoxemic respiratory failure. And this may avoid early intubation and invasive mechanical ventilation in some patients of COVID acute respiratory failure. Next, when the patient becomes too much tachypneic, or he has become hypercapnic, or he needs a little higher PEEP, then we can use non-invasive ventilation. And finally, once we fail with these three modes, we will have to think of intubating the patient. And for intubating, you have to decide according to the clinical acumen, the oxygen saturation, the dyspnea, and respiratory rate. We don't wait for a ABG. Intubation is always a clinical decision. Looking at the patient, the way he is breathing, the amount of saturation problem, from there we decide this patient will need intubation, he is going to fail. Now, the next part is anticoagulation. So I told you two drugs which are needed for COVID-19. One is steroids, second is anticoagulation. So this is a disease which has got a lot of thrombosis. The amount of thrombosis is much higher than any other disease or any other critical illness. So over the last 1 year, people have tried different doses of thrombosis and thromboprophylaxis. But after 1 year, what we have learned is standard dose of prophylaxis is indicated in all hospitalized patients. That reduces mortality. And increasing the dose to intermediate dose doesn't give you any benefit. Full anticoagulation critically in patients means therapeutic dose increases the mortality of these patients. So empirical full anticoagulation in critically ill patients should be avoided except in patients whom you have proven that there is pulmonary embolism or thrombosis. So the message is everyone should get a prophylactic dose of low molecular heparin when he is hospitalized, but do not increase the dose to intermediate dose or therapeutic dose unless you have evidence of thrombosis in this patient. The next thing, which again is prevalent, is doing a D-dimer. And from these four multicentric RCTs, the data which they have analyzed is D-dimer doesn't decide when you should be giving your thromboprophylaxis, when you should be increasing dose and all that. So D-dimer is futile as far as taking a decision about your dose of heparin. So this is in moderately COVID patients, there is a cautious optimism that it might improve outcome, but D-dimer levels have no bearing on outcomes. The last thing about anticoagulation is post-discharge thromboprolysis is unlikely to be beneficial. So the standard summary about anticoagulation is every hospitalized patient should get standard thromboprophylaxis. There is no benefit to increase the dose to intermediate dose, and D-dimer stratification thromboprophylaxis doesn't benefit, and you don't need extended thromboprophylaxis post-discharge. So this is the message which you have got from last year's studies on anticoagulation. Now coming to stage 3, case 3, this is a 40-year-old female with no comorbidities. She had fever, cough, shortness of breath, and multiple episodes of loose stool for 7 days. When she came into the hospital, her saturation was 86% on room air, respiratory rate was 20, BP was normal, ABG GPF ratio was 160, and RT-PCR was positive. A CT score showed 15/25. Now, initially, we did the labs, the ferritin, the D-dimer, these other labs, which was not much abnormal. So because she was hypoxic, she was started on Dexona, enoxaparin, remdesivir, antibiotic, vitamin C, zinc, and of course, oxygen. She continued to become dyspneic and hypoxic. Her oxygen requirement went up. So by day 3, she was on non-breathing oxygen mask with reservoir. By day 4, she needed NIV support, and then the PF ratio dropped to around 18. So anytime a patient deteriorates, the antibiotic is escalated, the steroid was also escalated, and then we did a dimer. Again, I said it has risen, the CRP has risen, so he has again gone into a hyperinflammatory state. The IL-6 also has risen. So this is a patient where we started thinking of tocilizumab. But unfortunately, her urine showed infection, so we didn't give her tocilizumab. So the patient was given a plasma, convalescent plasma, but she was electively intubated and mechanically ventilated on day 8. And we continued lung protective ventilation, proning, and neuromuscular blockade. So she is still in the ICU. She is still on these ways of mechanical ventilation. So to give you some idea about cytokine storm, this cytokine storm has become a big buzzword in this COVID-19 pandemic. But the amount of cytokines stimulated by COVID-19 is much less than what you have in septic shock on ARDS or bacterial ARDS or sepsis. So we have more cytokine storm during ordinary bacterial ARDS and bacterial sepsis and septic shock than in cytokines. So unnecessarily people are overhyping the terminology of cytokine storm. But during the hyperinflation, in tocilizumab has shown benefit. So out of these studies, 2 studies have shown that if you give tocilizumab at the right time, the mortality may reduce. So the recommendation is tocilizumab should be given in combination with dexamethasone in certain hospitalized COVID patients exhibiting rapid respiratory decompression. So the patient who rapidly deteriorates might benefit from tocilizumab. People who rapidly have hypoxemic respiratory and get into the ICU within 24 hours, you can give tocilizumab. There are some recommendations that outside the ICU also, a person whose oxygen requirement rapidly increases, you can give tocilizumab, but it has to be avoided if you have infection or immunocompromised patients. So all the RCTs have been reviewed by the National Institute of Health. The NICE of UK and the Infectious Disease Society of America, and they have said that if there is raised inflammatory markers within 24 to 48 hours of requiring high flow nasal cannula or NIV or invasive mechanical ventilation, then you can consider tocilizumab. Now, some practice guidelines about tocilizumab. Patients with rising CRP, IL-6, and low or stable procalcitonin with progressive hypoxia, despite steroid use, should be considered for tocilizumab. Values of CRP more than 100, IL-6 more than 80, procalcitonin less than 1 should be viewed with particular concern. Patients who have a high IL-6 but are not hypoxic are improving. You do not need to give tocilizumab. That IL-6 will get down in 48 hours. The dose of tocilizumab is 400 milligram, which is 8 milligram per kg, a single dose. You can repeat the dose within 24 hours, another dose. Repeat testing of IL-6 is not useful. So the IL-6 can be raised for weeks together. And if you have significant liver disease, then it is a contraindication for using tocilizumab. Now, Government of Odisha has formed a committee of which are the patients where you will give tocilizumab. So you have to go through that committee, and then only the government will issue tocilizumab for your patients. The next part was in May, an article from the father of ARDS, Gattinoni, said that there are two types of ARDS. One is the L type and the H type. Now, people started working again to find out if Gattinoni, what Gattinoni is saying is correct or not. And two articles in the same issue of Lancet Respiratory Medicine on 27th August showed that, one from the US and one from the Europe, that the ARDS in COVID-19 is same as other ARDS. So it is not different, it's not two types. So we have to treat this ARDS similarly like what we treat other ARDS patients. So the ventilatory strategy for ARDS in COVID-19 has to be lung protective ventilation. Your tidal volume has to be low, 4 to 6 ml per kg predicted body weight. Your plateau pressure has to be low, less than 30, and your driving pressure has to be low, less than 15. You can use neuromuscular blockade for the first 20 to 48 hours, and you should try prone ventilation for at least 16 to 24 hours till the oxygenation improves. So these are classical ARDS ventilation. You don't need to ventilate them in any other way. Like you think ARDS of COVID-19 is different. Now, what is the problem we are facing in the ICU is most of these ARDS, the lung is so stiff that once we intubate them, we are not able to ventilate them. So these are the patients who will need ECMO. And the use of ECMO in this COVID-19 epidemic has increased. And people with good ECMO centers with good experience, the mortality has been very acceptable. Mortality of 38, 31, 40%. So ECMO is the next step when your lungs are so bad that you are not able to ventilate. Unfortunately, we do not have much ECMO facilities in Odisha. We have 3 centers in Bhubaneswar, and they are again very initial stages of their experience. And the number of patients who need ECMO because we are not ventilating is very high. And this is what we are not able to improve or increase in our state. So that is why we are losing a lot of people after intubating and ventilating them. So the invasive ventilator is getting into disrepute because of this. So that is why people are prolonging non-invasive ventilation till the end, because if we intubate, we are not able to ventilate them. So if you had the facility of ECMO, then these are the patients where we would have intubated them early and gone in for ECMO. So summarizing the treatment part of it, no antivirals have been found to be effective till date. Steroids are only indicated in hypoxia for 5 to 10 days. But the type, the duration of corticosteroids, the timing of initiation, and the role of higher dose is still not known. Tocilizumab has a role in some patients. Prophylactic anticoagulation for hospitalized patients. Standard oxygen therapy and high flow nasal oxygen can be used where indicated. NIV in selected cases. Invasive mechanical ventilators where indicated. ARDS lung protective ventilation as in other cases of ARDS, and then if you are not able to ventilate, go in for ECMO. So this was the treatment part of it. Then I will come down to another 2-3 aspects of this COVID second wave. This was case 4. This is a patient who was admitted with fever and shortness for 2 days. So very rapid deterioration of this patient, 2 days only. And his saturation was 61 when he came to us. His CT score said 25/25. So he was admitted, given remdesivir, steroids, low mercury heparin, oxygen. He needed non-invasive ventilation, and then ultimately he was intubated on 28/4. So after 15 days, 5-6 days after, suddenly he desaturated and he found that he had developed pneumothorax. ICD was given, but ultimately he died in another 6 days' time. Now, what we have found is that pneumothorax has been one of the rarer complications of COVID-19, and a lot of literatures are now coming in. This is the first paper from India, 15 cases from Gangaram Hospital. And then we have mortality is very high in these patients. So 13 out of 15 died in Gangaram. And what are the causes of this pneumothorax in COVID-19 pneumonia? They think that this is because of some pathologic lung damages, which are complicated and multifactorial. And if you are using non-invasive ventilation, also you can have patient self-inflicted lung injury, which will increase your tidal volume. So these are the 2 things which you are thinking the patients may cause pneumothorax in these patients. Pathology of these patients, this was a 16-center study of pneumothoraxes on pneumomediastinum, 71 patients, and they found that 60 of them had pneumothoraxes, some of them had pneumomediastinum, and they found in histopathology, the major thing is because of the continuing inflammation in the lungs, there were cysts in the lungs which could have ruptured, and in one case they found pulmonary infarction. In our Indian study from Gangaram, none of them had got a CT done or a pulmonary infarction, but they couldn't know the cause. But this is what probably is the largest series, which says that probably lung gets damaged and causes cysts, which lead to pneumothorax. So ultimately, they said that these pneumothorax are secondary to the consequence of COVID-19. So the COVID-19 inflammation in the lung is the result of this pneumothorax. So we have come across 4 cases of COVID-19 leading to pneumothorax. 2 of them were in the first wave. The other 2 are in the second wave. Unfortunately, all of them have died. But what is important is all these patients developed pneumothorax 2 weeks after. So the first case after 37 days, second case after 90 days, third case after 30 days, fourth case after 21 days, which I presented to you. And the first case actually was not due to, so none of them probably were due to ventilator-induced lung injury. The first case, we were in the verge of winning the patient and she landed up with pneumothorax and ultimately had bleeding, clotting of the ICD, blockage of the ICD, and we lost the patient. The second one, of course, was on non-invasive ventilation, so we don't know if it was self-inflicted NIV cause. The third also was on NIV. The fourth one was already intubated, heat pressures and saturations and everything was normal, and suddenly he deteriorated. So the cases we have encountered, we still think that the COVID-19 inflammation has caused destruction in the lungs and caused pneumothorax. The last case which I would like to discuss is a doctor who is diabetic mindly. He is on COVID duty, developed fever on 18/4/2021. He had completed his vaccine in January and February. After 4-5 days of fever, he just wanted to see if he had developed COVID, so he did a CT thorax, which was normal. But once the fever persisted, on the 6th day, he went and did a RT-PCR, and that turned out to be positive. Of course, he had mild symptoms and recovered in 5 days' time. But what I want to point out here is, in the second wave, after the vaccination, we have already got 20 cases of breakthrough infections in every hospital. So people who have been fully vaccinated, have completed 15 days after the second dose, have got infected again. So that is why the recommendation is, even if you are fully vaccinated, please keep your mask on. And because we are healthcare workers, we are having COVID patients in the hospital. So in spite of vaccination, we have to use a N95 mark in the healthcare setting. And we have to ensure that the patient attendant should wear mask properly by covering their nose and mouth. So that is how we can probably prevent breakthrough infections. So this is the guideline. Government of Odisha probably anticipated that even after vaccination, you could have breakthrough infections. So they have sent this circular on March 19 that vaccination status of the patient needs to be captured in the SRF while you are collecting the swab for testing. And if a vaccinated person is found to be positive by any laboratory, the sample has to be sent to RMRC for confirmation. And from there, probably, I talked to ILS where genome sequencing is being done. So probably those samples may be sent to ILS for genome sequencing. So world over, even with mRNA vaccine, which is 90% effective, 5,800, and to the last count, it's around 9,500 patients have got breakthrough infections, but very few, only 74 people have died out of, say, 77 million people, and around 400 to 500, 550 patients have got hospitalized after breakthrough infections. So in conclusion, after these 5 cases, what I would like to conclude is treatment of COVID-19 needs to be streamlined according to the evolving guidelines. So 1 year has passed. We have got lot of evidences now. So we have to start following those evidences for treatment of COVID-19. There is unnecessary use of medicines for prolonged periods. So we are overusing medicines. We are overusing them for prolonged periods. Oxygen infrastructures to be upgraded in all healthcare institutions. Medical leadership should give clear messages to the doctors and public to prevent confusion. We are still at azithromycin, ivermectin, Montecalci, doxycycline, and the medical leadership has to step in and tell everyone what is the current recommendation, not what was there 1 year back. Pneumothorax is a rare complication COVID-19 lung damage, and breakthrough infections can occur after vaccination. Therefore, all healthcare professionals need to use N95 masks inside high-risk areas. With that, the last slide I would say is COVID-19 is far, far away. It may take another 1 or 2 years for things to settle down. So let us not relax. Let us continue the fight and precautionary measures, because the only way to have a third wave, a smaller third wave or a smaller fourth wave is to continue COVID appropriate behavior and get your vaccination as early as possible. Thank you.
Thank you, sir. That was a fantastic presentation by Dr. Shamir Sahu, not because all the cases were carrying a special scenario and special message, but he has given a very clear concluding guideline regarding how we should proceed, and very clearly concluded that these drugs which are uh, not very appropriate, we are using a lot of repurposed off-label drugs which neither shows any evidence nor we know that we can stop them using, and people are confused. Somebody is telling take ivermectin, WHO telling it doesn't work. Somebody telling take remdesivir, WHO telling it's doubtful. So even convalescent plasma today, ICMR has given a clear nod that this is of no use. All AIMS and ICMR has concluded. So being a pandemic scenario, lot of opinion and counter opinions in the treatment strategies have confused not only people at large but medical professionals. So medical leadership and clear pronunciation of the treatment guideline and whatever evidence available basing on that, like desaturation, steroid, low molecular heparin, and other supportive drugs, maybe a injectable antiviral. So whatever guidelines are evidence based, we need to go by that. So thank you, sir, for interesting cases and clear message to our delegates. I'm sure you all will be benefited, and also people watching this in the YouTube will take a clear message regarding management at this juncture. So not only Dr. Shahu has told the approach, but told about the rare complications like pneumothorax and also the breakthrough infections in people who have been vaccinated adequately with first dose and the second dose. So thank you, sir. It was very clear, and we had very message which is very evident for our delegates. We have few questions, and we can conclude the program early because we are having now short and direct programs of a resource person in the grand rounds, which gives a clear message. And for today, the message is very clear. And the questions which has come, Dr. Nishit Mohanty has asked that if remdesivir is of doubtful efficacy or no efficacy, why not government is why there is government guidelines? Uh, um, why government is not giving guidelines that this is not a necessary drug for the COVID? So I think Dr. Shahu to tell his opinion in this regard.
See, government has not changed its guidelines since 1 year, and this is how the government machinery works in our country. We do not delete anything. We just keep on adding, adding, adding. So our culture is that no one wants to take a clear decision. See, AIMS guidelines have removed a lot of these unused drugs which I showed you in the first list. So someone has to step in. That is why I'm telling you, the medical leadership has to step in and overtake the political leadership. We are still afraid of the politicians, and that's why we keep quiet.
Sir, another couple of questions has come in chat box. I'll be reading them for the benefit of all our delegates. The first one, why a second wave became so fast and furious, and the picture which we saw in the first wave was very slow and less furious than the second wave. And can we attribute any human cause in this second wave pathogenesis or the outcome?
See, there are numerous causes. The first thing is probably we are dealing with a variant. Second thing is the first wave and the second wave, the year is almost 6 months. So people who are mildly infected, their immunity has gone. And third thing is we stopped COVID appropriate behavior. In March 1st, we opened up everything. So all three are responsible for the massive second wave. The variant, of course, is responsible for the rapid transmission, and maybe it might be more fatal also. We don't have much data, but all the three are responsible for the massive second wave.
Thank you, sir. Another question has come that shifting of the infection train to the younger mass. It shows almost the youth population of the patient are doubled. So this is because of the vaccination of the elderly mass, or the virus shows a special trend for the children and the youth.
We still don't have enough data. We have to wait to analyze our data. The trend in the Western world is the same. The first wave and the second wave were similar, but the second wave was more furious than the first wave. So in India, it's too early to talk about these things. We don't have enough data, and our data keeping is very poor. So unless we have good data, unless the wave finishes and we analyze that, we cannot tell that younger people. Because more people are being infected, naturally younger people will also come in. But the experience of the Western world is it's a similar pattern, first wave and second wave. Only second wave had more cases than first wave. And that is what we are seeing in India. So it's too early to talk about younger people coming in. See, if you have 100 people getting infected, some younger people will definitely come in. So I showed you 2 or 3 cases which were younger, very young, 30, 20, that type of cases. So that type of cases you will get. But we still cannot say that this wave has more younger people than the earlier wave. We have to wait for the wave to go up and then we analyze our data.
Sure, true. Because the infection numbers are increasing. Naturally, the number of people who are getting sick will increase. So there is another question that one of the case also you have presented, that the patient suddenly deteriorating and going for invasive ventilation and succumbing. Though they are in the hospital for quite some time, maintaining saturation with 3 or 5 liters of oxygen. So what, as rightly you have pointed out, the inflammation may be a cause. So for them to prevent this sudden deterioration and the loss of the patient, can anything be added in the initial management, or can anything predict their deterioration?
So that is what I'm telling you. Good clinical acumen and good monitoring. The unfortunate thing which we are facing is no nursing, no doctor manpower. The ratio of people working in COVID setups is so atrocious that we are not able to monitor any patient. So that is what I'm telling. So there are people who will behave differently. Some people will go have chronic slow infection. Some will have a inflammation suddenly. Some will have hyperinflammation. So that hyperinflammation we have to catch early and treat them. So that is what you give steroids, maybe tocilizumab. So those are the patients who you can salvage. But that we are not doing. We are not able to monitor them clinically. We are only bothered about doing investigation and markers. Clinical monitoring. See, what I am seeing in this wave is because the wave, more number of patients are coming, people are coming 10-day, 12-day with no remission or recurrence of symptoms. So those are the patients who have gone into inflammatory stage. Some of them will definitely have a hyperinflammation and suddenly deteriorate. So clinical monitoring is more important than depending on the biomarkers. And biomarkers are being actually misused. Every patient is doing his blood tests, biomarkers and CT scan and coming to us without talking about the clinical symptoms. I do at least 5 to 10 teleconsultations every day. Everyone sends his reports instead of talking to me about the symptoms. No one talks about what is the duration of fever or what is the duration of cough or breathlessness. They start off with saturation and the reports. So we have to be clinicians first, and then only we can detect the deterioration and treat immediately.
Rightly shared, sir. The patients are thinking that the doctor will require the reports, and doctor will require the oxygen saturation value, than listening to the story or the symptoms of theirs. That's a very wrong notion, and people are going of their own, not once, almost daily or alternate day, repeating the test, repeating the scan, they are seeing like ICU patients are done for monitoring. They are also doing that at the home isolation and at those who are not infected and sending the reports to us and insisting for the advice. So that's very wrong trend. And as you are told rightly, the inflammation from the hyperinflammation is to be differentiated very carefully, and timely intervention may save the patient. The last question that we are having in the chat box, last two questions. The next is regarding the vaccination. There is a question: if we complete our target vaccination, will it be helpful to prevent the third wave?
See, what I was analyzing is those people, we had a lot of nosocomial infections of the healthcare workers in September. But in April, May, that has come down. And that has, because see, we are dealing with the second wave where the number of cases are more. The transmissibility is more. But the healthcare workers getting infected is less. So that means our vaccination is working. So the target population, of course, there have been a lot of health workers who have not taken the vaccine. There is vaccine hesitancy in them. Then the message that pregnancy and lactation you cannot take. So you see 50% of the nurses are either pregnant or lactating. So they are excluded from vaccination. So quickly the government has to change these things if we actually want to make a progress. So vaccination is definitely going to protect you. It may not protect you 100%, but India as a country of 130 crore people, we will never be able to reach 10 or 15% of vaccination population. So you will take your vaccination, you will be protected. But herd immunity will never come in India due to vaccination. We will never be able to vaccinate 70-80% of our population. And what has happened is once you have opened up this 45 to 18, the people are pushing the people who are more needy for the vaccination, and the vaccination centers are becoming a source of infection. So we have mismanaged the vaccination program after opening it up in May.
Sure. People are so restless. We see thousands of people are in queue from a very early morning to get a token for the vaccination, and there is a lot of overcrowding leading to spread of infection. All the distancing and the norms are violated. So we have warned people not to do that, because vaccines will be there for everyone. Gradually, we have to complete this slot. But the Indian nature, very restless, and they think that vaccines will be exhausted, and they're uh, all are eager to take it. So last question, sir, it has come. The initiation of steroid at which point of time in case of our patient, because most are not able to recall their symptom. If you ask about the breathlessness or the chest discomfort or the desaturation point, and those who are specially at the home isolation and on close observation rather than in the hospital, as you have rightly told, hospital also we are having very less doctors, less trained staff to detect the point where the patient desaturates, and I should go for all therapies, including low molecular heparin and the oxygen, and as well as the steroid. So, what is the right time for initiation of steroid, and what steroid and which dose? The last question which has come to us.
Okay. So the first thing is, I told you, clinically, if the fever is not getting better over a period of 1 week or so, because 1 week is the time we say the viral replication stage is over. So if after 1 week also the fever continues and high spiky fever continues, then I think you can give a dose of steroids. Depending on what is your clinical judgment, what is the level of inflammation, you can start off with low dose, or for diabetics, you have to be careful. So I have started, see, a 70-year-old person, diabetic, his fever persisted for 10 days. So what I did was just gave him 10 milligram of prednisolone for 5 days, and he's all right, he becomes all right. So depending on what is your inflammation, your steroid dose will change. But the recommendation for steroids, that 6 milligram of dexamethasone or 40 milligram of prednisolone or 32 milligram of methylprednisolone is for severe and critically ill people who are hypoxic. But you can start a lower dose for people who have completed 7 days and are not showing improvement. People who are hypoxic, definitely the loading dose. But here I told you, people who are hyperinflammation, like I showed you in one case, from 40 milligram twice a day, we hiked up to 125 milligram twice a day. So that may be necessary according to your clinical judgment. So I told you, still the last word about steroids, we don't know. So we don't know when to start. We don't know how long to continue. We still don't know what dose to give and when to increase the dose. So that will take time for more evidence to come in.
We know that dexamethasone is longer acting than the methylprednisolone.
Yeah, so but prednisolone, methylprednisolone, you can give once or twice a day also, no problem.
Sir. So thank you, sir, for all those answers. Our delegates have really benefited, and I'm sure much more people will be benefited after watching this program in the YouTube. You have told the complete latest guideline and also covered the interesting cases, also told about the rare complications like pneumothorax, like the breakthrough infections and the status of the vaccination and the possibility of defending the third wave, and they have also covered clear guidelines about the drugs like tocilizumab, steroid, anticoagulant therapy, and breast. I'm sure taking your advice, many patients will be benefited. And again, we'll listen to you in this grand round. I thank you for your very informative presentation. I thank the Department of Health and Family Welfare, SCV Medical College, whole team for the program, and all our panel, Professor Niveta Pani, Professor M.R. Patnaik, and Professor B.K. Dash, and the whole team who are involved in the program, including Professor Chaini, Nirupama Chaini, and also our DMT chair, Professor C.V.K. Mohanty, for starting the program and encouraging us for the capacity building. Lot many instructions and these short recordings are there in the website of Department of Health and Family Welfare. So I request all the delegates to please download and also utilize those material for updating. So that's all for today. I thank everyone. Thank you, Shamir Shah. Thank you, delegates, and hope to see you again on Tuesday in our program. Thank you, sir.